for OA flexion. By the same token, we could have a restriction for OA extension, right? So I could oscillate back this way, kind of engage the barrier and decide whether I would do a grade 4, a grade 3, a grade 2. So you could do the same thing that we've done before. If I were going to try to take him in towards the barrier and then do a hold relax, I'm now probably going to come and ask him to pull his chin down just slightly. So he's activating what muscles? The deep neck flexor, so longus colli, longus capitis. So you're trying to, again, get that happening. I'm not trying to get SCM happening where he would then flex his head on his neck, so to speak, okay? So I want it to be those deep cervical flexors, and I can give that tactile cue there. All right, the AA joint, you described perfectly good techniques. I could, if I assessed him this way, I can take him to the barrier and then just oscillate, and I'm providing my mobilization force through this hand, not through this one. So I just take him into that oscillation, engaging the barrier, if that's appropriate. I could take, if I decided I wanted to do a hold relax here, I usually will take him to that point and then sort of switch my hand position so that they have something to push back against. If I'm here, then I have to do something to give them the tactile cue to rotate the opposite way. Or as Sharon demonstrated, I could do this very same thing with my facet positioning, and then asking them to gently turn the opposite direction. So those are great options for treating somebody with a limitation at the AA joint. Can I have you sit up? Yeah. Sometimes I'll find that, I'm not going to have you sit down here. I'll find that I want to treat them in sitting, or I haven't been as successful as I wanted to in treating their dysfunction with my other techniques. So another thing that I will do is I'll do a technique where if I am working, I'm going to say left rotation for now, and then I'll show you guys from where you are. So if my patient was turned this way, and I say, okay, I'm trying to improve rotation to the left, so I want occiput and C1 to rotate towards me, but I don't want C2 to go, right? Because I want to get that nice isolation to this joint. So the way I can do that, if my patient is sitting here, I can take my thumb, I'll find C2, and then just bring my thumb laterally, so I'm over either that the posterior lamina or out towards the articular process. So that's going to block, or attempt to block, C2 from rotating towards me. Then I'm going to take my hand, so it cups occiput and C1, and then my biceps, and I think I'm saying the right muscle, will be on their forehead, and I think I said the right body part, and then I will just give my rotation like this while I'm blocking C2. And then I can ask them, they can do a hold relax from here, I can oscillate from here. It's a great, great technique to do. Turn around.
Could you block the spinous process too from the other side?
You can, but I find it easier personally. I don't know about you, Scott. Do you ever try to block the spinous process with it to keep it from swinging out that way? With this technique?
I'll do what you just did.
Yeah. It's theoretically, it's absolutely possible. It's just a matter of whether you have enough real estate to effectively block it, would be that's my problem with it. So I guess it might depend on the anatomy of the person, but for me, this is just so much easier because I can kind of sink through, and I'm just sinking through the soft tissue, and then as you start to come, you'll kind of feel it sort of push into your thumb, and you'll know that that's the limitation. So it's, for me, it's just, you can try it the other way. I think you'll find this is a bit easier. But it's a really nice technique to do. I can add a little bit of, this stool is a little bit high for me to do this, but I'm just coming around here, so I've got occipits. My pinky is around posterior arch of C1. find spinous process of C2, come out laterally on the lamina, and I'm not pushing this forward real significantly. I'm just going to use it to kind of keep it from moving back. So I'll take him to the barrier, and then I can oscillate. I can have him gently try to turn back to that would be the right. I can do my hold relax. I can do a little bit of distraction with it. So it's just like any of the others. I find it a useful technique. Now, that said, we still have I guess I switched it out when we were saying right rotation, but let's say we still have this restriction of left rotation at the AA joint. Can you think of a way, can somebody teach me a way I could do this in prone? What would be the thought process for how you would do it? So could you imagine if I put my patient prone, and we're going to say that they were limited in left rotation. On the table, I had them slightly turn to the left, so whatever degree kind of approaching what would be the barrier, and then find spinous process of C2, come out laterally to the left, and do a PA at C2, which essentially rotates it the opposite way and still creates a left rotation moment at AA. Does that make sense?
Is that why you're rotating to the left?
Yeah, so this isn't a great table to do it on because there's not a breathing hole there. Can we maybe use that one, Jenna?
I can move a little too.
I'm recording. I need this for later. I can't remember.
All right, so again, if we're thinking at the AA joint, we have somebody that in this case is perhaps limited in left rotation. So I'm going to move him into some slight left rotation, not enough where it would take him beyond C1, C2. Then I'm going to come and find the spinous process of C2 and then just come out laterally. And now I'm just going to do a straight posterior to anterior pressure on C2, which creates a relative left rotation moment at C1, C2. I would advise you when you start doing this, get the flexible spines, put them down there so you can see visually. It'll make a lot more sense to you. But can you see?
Can you say again what you're using?
Okay, so I'm trying to improve left rotation at AA. If I take him towards the barrier, I take him into left rotation, here would be my options to improve rotation at AA. I could try to come on the posterior arch of atlas on the right side and do a PA there, but that's kind of hard to get down on the posterior arch of atlas. Plus, when he rotates, now I've moved that where it's hard to really do a straight PA. But if I take him now, instead of doing a right PA on C1, and instead do a left unilateral PA on C2, I'm still creating the same effective rotation moment at C1, C2. So C1, occiput and C1 have rotated. Now I'm going to come on C2 and push it over here, which will just increase the effective left rotation of C1 relative to C2.
When you're doing the PA on C2, do you stabilize C1?
No, because I've taken them kind of towards the barrier. There's not really a great way to stabilize that, so no. I don't know of a way to stabilize it. Stabilize C1 on that. Get the flexible spine and you'll see. Like I said, I'm just coming, the spinous process of C2, I come out on the lamina so that I'm on the left side of C1. So Scott, come here for a second. Could you So kind of go like this. So Scott, let's put you on a chair. So if Scott is C2, and I'm sitting up here as C1, I can try to improve left rotation by, Bill, can you come over here? You be C1. Okay, so he's C2. Scott's, or Bill's up here as C1. If I'm trying to improve left rotation, Scott stays still. Bill and occiput can kind of do this to rotate, to create left rotation. They come back. Manually, if I were going to try to do it, I could try to come on the posterior arch of atlas on the right side and do a PA to kind of create a left rotation moment, right? But it's hard to do that. You've got a lot of thick tissue. It's hard to get a sense of the underlying bone on the posterior arch of C1. So to create a relative left rotation moment there, and I can't really do it from here, I'll say, okay, I can outsmart you. I can find the spinous process of C2 here and come here and now do that, which creates a relative left rotation of C1 relative to C2. So now, you step this way, and Scott, we're going to...
It does.
See how that's left rotation? Now go back. I did it by pushing here, but it still is.
Your video.
Very good, guys.
That's our perception.
Oh, gosh. So why don't you take a